Hello everyone. So we have a 34-year-old male and he got involved in motor vehicle accident. He suffered blunt abdominal trauma and bilateral femur fracture. His blood BP is 80/40, that means is hypotension, most likely due to bleeding, tachycardia, several units of PEC, RBC are given, and he had tingling sensation in toes and fingers. His serum calcium is noted to be very low. Most likely cause of this current symptom. Answer is B. Calcium chelation by a substance in the transfused blood. Well, let's go into detail. Patient is experiencing paresthesia due to hypocalcemia. We are well aware that in hypocalcemia, patient can have paresthesia. And how do you say a tingling sensation in toes and finger? That is paresthesia. Significant blood loss is there. Why? First of all, accident is there. Blunt abdominal trauma is there. Bilateral femur fracture is there. And moreover, BP is 80/40. That supports the diagnosis that he got massive blood losses there. But before I proceed further, I have a question for you. Write down the answer. The question is, how much blood loss can occur in a closed fracture of femur and pelvis in ml? Write down the answer. Options are 50, 100, 250, 500 and 1000 ml blood can be lost. What is your answer? Well, it is very important to know how much blood loss. Blood loss can be as high as 1000 or even more than 1000 ml also. And it is sometimes, it's a closed fracture. Closed fracture and the bleeding is not visible outside. No bleeding visible outside. And massive blood loss may be there. So in this case, that's the reason why BP is low and they are trying to give PEG cell as per resuscitation. He received several units of RBC PEG cell what were given to this patient. Now when we use blood for storage, we use a chelating agent, we chelate calcium. And citrate is the anticoagulant that we use that chelate calcium. So when you transfuse, that lead to hypocalcemia. This hypocalcemia what lead to paresthesia. Okay. So as I told you, even PEG cell also is collected in citrate, which can chelate calcium as well as magnesium. Both can be chelated by citrate. So they lead to not only hypocalcemia, they also lead to hypomagnesemia also. So definitely, now when we talk about massive blood transfusion, what do you mean by massive blood transfusion? Equivalent to more than one blood volume over the 24 hours. If a patient is getting more than one blood volume over 24 hours, then we call it to be massive blood transfusion. Now, I have one more question for you. Write down the answer. What is the ECG finding of hypocalcemia? Answer is, this is the normal recording. This T wave. This is QT interval and this normal. In such cases, QT interval is prolonged. It's a classical finding that we get in hypocalcemia. Well, option C, electrolyte leakage from RBCs during pre-transfusion storage. Well, we all well aware potassium is mainly intracellular. And when we store the blood, it comes out and that leads to hypercalemia. Okay, remember that is all pseudo hypercalemia because it's not true hypercalemia but leaks out. But hypercalemia occurs no hypocalcemia and hypercalemia does not lead to paresthesia. Increased renal tubular secretion of calcium, it is done by furosemide. And that's why furosemide is used as a drug of choice in acute hypercalcemia. Again, I have a question for you. Write down the answer. What about action of thiazide about calcium in the kidneys? Answer is it tends to retain calcium. It can lead to hypercalcemia. Antibody-mediated RBC damage, this is seen in autoimmune hemolytic anemia. Okay, and definitely it is not a cause of hypocalcemia. Parathyroid gland suppression due to fluid overload. Parathyroid gland suppression due to calcium is not by fluid overload. It has fluid overload, has nothing to do. Fluid overload has concern with congestive heart failure. Okay, not with parathyroid gland. Golden line to remember: patients who have received equivalent of more than one blood volume of blood transfusion or packed blood cell over 24 hours may develop plasma level of elevated plasma level of citrate, a substance added to stored blood too, and they chelate calcium and magnesium, and they reduce calcium and magnesium level, which can lead to paresthesias. Hello everyone. So we have a 58-year-old lady who is undergoing systemic chemotherapy for advanced breast cancer, and there are metastases to bone also, and she has come for routine follow-up. She has mild vague bony pains that are relieved by occasional use of acetaminophen. That means the pain is not very severe. Examination shows a well-healed mastectomy scar on the right and a palpable right supraclavicular lymph node. Mucous membrane are moist, and the lab reports are as follows. Well, if you look into lab reports, only visible abnormality is slight increase in serum calcium level. Rest all the reports are in the normal range. Well, what is the best in the next step in the management of this patient? Well, answer of this question is A, that is biphosphonate therapy. Well, this patient has come to us with mild hypercalcemia. It is 11.4 milligram only. We all know very well the normal level of serum calcium is about 9 to 11 milligram per cent. So this 11.4 only mild hypercalcemia. Well, that also in the setting of metastatic cancer to bone. Well, patient having no symptom or mild hypercalcemia when the calcium level is less than 12 milligram per cent does not require urgent therapy. But hypercalcemia or malignancy may worsen over the time because she already has bony metastasis. Now, we use biphosphonate in such cases, especially in the setting of bony metastasis, like zoledronic acid. What the mechanism of action, what they are going to do, how they are going to reduce serum calcium level. They inhibit osteoclastic activity of the bone. They stabilize destructive bony tumor and reducing malignancy, hypercalcemia. Net result will be they will reduce hypercalcemia of malignancy. Now, when we are giving biphosphonate therapy, some fractures are very specifically seen in this patient. Which fractures are common with biphosphonate therapy? Write down the answer in your copy. Well, the answer to this question is subtrochanteric fracture. Look into this. Subtrochanteric fracture are very common with this patient on biphosphonate therapy, and of course there is one more very important side effect is it can lead to intense esophagitis. Okay. Let's look into other options. What about steroids? They are useful for hypercalcemia related to granulomatous diseases like sarcoidosis. They reduce calcitriol release from the activated mononuclear cells. However, they are not effective in hypercalcemia of malignancy, which operate via different mechanism. But again, I have a question for you. Write down the answer. Which hypercalcemia occur? Why hypercalcemia occur in granulomatous disease like sarcoidosis, and of course like tuberculosis also, but classically they talk about sarcoidosis. Write down the answer. Well, the answer is why hypercalcemia occurs in granulomatous disease. It increased production of vitamin D, that is 1,25-dihydroxy vitamin D by the granuloma itself. So that lead to increased vitamin D synthesis. And why this happen? Because this is done by 1-alpha hydroxylase mediated vitamin D activation in inactivated macrophages. We all well aware that 25 hydroxy cholecalciferol is converted into 125 dihydrocholecalciferol, and this is done by the enzyme 1-alpha hydroxylase. And this activity is increased, that lead to increased vitamin D synthesis, and that lead to increased intestinal calcium absorption, secondary to high vitamin D level. And of course, the PTH level will be suppressed. So net result shall be increased calcium, increased phosphate, reduced PTH, and normal alkaline phosphatase. Option C, loop diuretic. This can be used in patients with moderate to severe hypercalcemia. In fact, this is used only when there is a medical emergency. It is not a treatment, a routine treatment for hypercalcemia. Okay, they are not used for a routine treatment. Option D, opioid therapy. Opioids are the first-line treatment for metastatic bony pains that not adequately controlled by acetaminophen or non-steroidal anti-inflammatory drugs. Okay. Well, patient is having adequate pain relief with acetaminophen, that also with occasional use. That means there is not severe pain, therefore additional pain control is unnecessary. But again, I have a question for you. For bony pain, we use fentanyl or we can use morphine. Now, write down the answer. Tell me the comparative of potency of fentanyl from morphine. Well, the answer is fentanyl can be given IV, IM, transmucosal, transdermal, epidural, intrathecal, pseudogensis on stick. So there are various methods by which we can give fentanyl. They're cardiac stable, the big advantage of this. And it is 100 times more potent than morphine. Imagine how powerful is that. What about option E? Radiation therapy can be treat moderate or severe bony pain caused by bony metastasis. It should not be indicated at the time because the patient has only mild pain. There is no question of giving this. Maybe radiation therapy, opioid therapy are not required because pains are very well controlled by mild dose of acetaminophen. Golden line to remember: biphosphonate like zoledronic acid and pamidronate are the drugs of choice for stabilizing bony metastatic lesion to prevent hypercalcemia of malignancy or even to treat hypercalcemia of malignancy. So we have a 66-year-old man. He come to you with a routine medical examination. He is hypertensive. His BP is at the moment is normal, pulse normal. So he had a very strong smoking history, but he quit 10 years ago. And no thyroid problem, no lymphadenopathy. Brew is in the right side of the neck. And chest auscultation shows no abnormality. And when we do the Doppler study, that shows 80% blockage on the right common carotid artery, bifurcation. And the left common carotid artery is 40%. What is the next best in the management of this patient? Well, out of all the five, option D is correct. That is right carotid artery surgery should be done. Why this the answer? Well, first of all, this is 80% blockage is there on the right side. On the left side, it's 40% lesion is there. And moreover, patient has no symptom at all, totally asymptomatic. And remember, patient just came to you for a routine physical checkup. No problem at all. So we can say he has bilateral carotid artery stenosis, but percentage 40% on right and 40% on the 80 on the right and 40% on the left side. But although his asymptomatic carotid artery stenosis is there, but it can anytime it can go on to TIA or maybe a embolic stroke also. Transient ischemic attack may be due to embolic phenomena, which can pursue to stroke. Now, what do you mean by symptomatic carotid stenosis? So far, we discussed about asymptomatic. Occurrence of sudden onset of focal deficit due to carotid artery lesion in the last 6 months. So there is a criteria that patient had a TIA, a stroke, with on the side of the carotid artery lesion. That is so-called symptomatic carotid stenosis. Now, what are the carotid endarterectomy is the surgery that we talk about, but where it is indicated, there are different criteria for men and women. So first we see the woman, whether it is symptomatic or asymptomatic, whatever it may be, between 70 to 99%, the patient should be subjected to surgery. And in case of men, asymptomatic 60 to 99, symptomatic 70 to 79, 50 to 69 also. Or you can say, we can make it simple, 50 to 99% symptomatic. Asymptomatic 60 to 99. But in case of woman, it is 70 to 99. The point to note it, that's why this is same as woman. So this point is extra. This point is extra. And of course, in this asymptomatic also, we are talking about 60 to 99%. So there are two differences between men and women. Okay. With this background, now our patient is asymptomatic, but 80% blockage is there, and he is a male patient. So that means right carotid endarterectomy should be done, and the other side is 40%, that doesn't come into the category of surgery. Now, I have a question for you. A patient come to you and he has 100% blockage of any of the carotid artery and he's asymptomatic. What will be your advice in the management of this case? This is the universal question asked in all the exams throughout the world. Lovely question. Well, the answer is nothing. Nothing. Why nothing? Suppose this is the artery and it is totally blocked 100%, but patient is totally no symptom at all. It means the patient has developed, by default, it has developed collaterals. The collaterals had already been developed. That's why despite having 100% blockage, patient is asymptomatic. In such cases, don't touch it. No need to touch anything. While simple day-to-day line, I say, if the lion is sleeping, don't irritate. It will create more problem for you. So now the answer is very clear to you that do we need to do bilateral carotid artery? No way. Other artery is only 40%, so no need. Okay, and left carotid artery surgery not required, because any lesion at 40% we don't need any surgery, as we have seen the guidelines. Okay, in such cases we don't need surgery, it's not indicated, but patient should be managed medically like antiplatelet therapy, statin, that is a must. Okay, surgery is not indicated, but medical therapy is mandatory, and risk factor modification, tobacco cessation, diabetes and hypertension control has to be done in all the patients, irrespective of the percentage of the blockage. Long-term aspirin therapy without surgery and no intervention needed are again wrong. Okay, aspirin is recommended for prevention, or it's a preventive drug, it's not a curative drug. Okay, so aspirin be used in coronary artery disease, cerebrovascular disease and peripheral arterial disease. In all these conditions, we use aspirin as an antiplatelet drug. It's a preventive drug. It's not a curative drug. Okay, so any patient who is already having some cardiovascular disease, we can and we should use aspirin, reduces the risk of further any bad effect. Okay, so in this case, given the degree of 80% stenosis, we have to go for surgery is the best answer. Now, golden line to remember. Carotid artery endarterectomy is indicated in asymptomatic patient, men between 60 to 99, symptomatic 70 to 99% or 50 to 69%. But in women, whether symptomatic or asymptomatic, 70 to 99% stenosis is the need. They should be subjected to CEA, that is carotid endarterectomy. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.